Hello everyone, I am Dr. Inass Kawtharani from the Lebanese, a researcher at Lebanese University and the coordinator of laboratory sciences at the Islamic University of Lebanon. I am honored to present our research entitled The Molecular Epidemiology of Different Bacterial Pathogens and its Antimicrobial Resistance Genes among patients suffering from surgical site infections in Lebanon, a multi-central study. So before going into details, let me show you how our presentation is organized. At first, I want to begin with the introduction, then follow the methodology and the results, and finally, I want to highlight the strengths and limitation and conclude with the future strategic perspective. So let's start with the introduction. According to the CDC and WHO, surgical site infection is defined as an infection can develop in the surgical incision after 30 days or up to 1 year if an implant is placed after surgery. So this infection today are a persistent problem in healthcare setting worldwide, mainly responsible for increased mortality and morbidity, dissatisfaction of patient, prolonged hospital stays, as well as higher treatment costs. And the most common causative of this infection are different microorganisms like different bacteria. And this infection are further complicated by an increasing multi-drug resistance organism. So, understanding bacterial pathogens epidemiology and resistance patterns that cause surgical site infection is crucial for implementing effective prevention and control measures. So to build on this idea, let's look what the previous studies have reported about the surgical site infection. Several studies have investigated surgical site infection globally, but today I wanted to list only two studies. The first one was conducted in Lebanon between 2015 and 2017 at the American College of Surgeons. They found that the surgical site infection incidence was 6.8% after lower extremity amputation in diabetic patients, and the different risk factors were associated with surgical site infection occurrence like smoking, emergency status, and preoperative sepsis. Then the second one, a review done by Iskander and his colleagues in 2018, highlighting the gaps in quantifying the economic burden of surgical site infection associated with antimicrobial resistance bacteria, identified major gap in surveillance method, epidemiologic data, evidence-based surgical site infection prevention practice, economic evaluation of surgical site infection linked to antimicrobial resistance pathogens, and a higher rate of resistance organisms were observed in inpatient compared to outpatient. And in high-income countries, the most common isolates were multidrug-resistant Escherichia coli and Staphylococcus aureus, and limited data from low and middle-income countries, including Lebanon. So in Lebanon, combating surgical site infection and their antibiotic resistance is a serious challenge due to the fragmented healthcare system and diverse population. However, data on the molecular epidemiology of bacterial pathogens and their resistance genes in surgical site infection is still very limited, which creates a gap in our ability to implement effective measures. So all that encourage us to this study that it address the knowledge gap by generating evidence in surgical site infection prevalence, resistance profile, and association between different characteristics and surgical site infection occurrence, so we can guide the evidence-based intervention for preventing, controlling, and better management of this infection in Lebanon. So our study had four objectives. One, to determine the prevalence and distribution of bacterial pathogens causing surgical site infections at Lebanese hospitals. Two, to characterize the antibiotic resistance profile and identify the resistance genes associated with these bacterial pathogens. 3, to investigate the association between patient demographics, clinical characteristics, and bacterial epidemiology. And finally, to explore the potential risk factors can affect the presence of surgical site infections in Lebanon. So now let's move to the methodology of our study concerning the study design and setting. It was a multicentral, cross-sectional, national, and prospective study conducted in 7 hospitals across Lebanon between January 2024 and February 2025 with IRB approval from each participating hospital. Now, let's look who participated in our study. A total of 300 patients who underwent surgical procedure were included in our study. It were divided into 2 groups. The first one, the infected group, consisting the patient who developed surgical site infection, and the second one, the control group, included the patient without surgical site infection. And data were collected using a specific or a data sheet designed for our study. It includes different characteristics like sociodemographic details, clinical characteristics, hospital-related factors like duration, surgery duration, hospital stay duration, antibiotic prophylaxis, wound class, and ICU admission, and another characteristics, and a relevant medical history from patient, and this data were collected from the patient's medical record. So now let's proceed to the laboratory procedure. It consisting 5 main steps. Number 1, the sample collection under strict aseptic condition. Number 2, bacterial culture and identification using different media and biochemical tests. Number 3, antibiotic susceptibility testing using according to CLSI guidelines and using the disk diffusion method, and using different bacteria, different antibiotic like beta-lactamase, carbapenemase, macrolide, glycopeptide, aminoglucoside, fluoroquinolone, and etc., depending on the bacterial type. Then number 4, identification of specific resistance strains like extended spectrum beta-lactamase, MRSA, CRE, VRE, and MTR. And finally, molecular detection of resistance genes. In this part, many steps were performed. We started from the MDR multidrug resistance isolates, then extracted the DNA and performed the real-time PCR to detect the presence of specific resistance genes. So DNA was extracted using the phosphor-nucleic acid versatile extraction kit. Then it consisted at different steps, sample pretreatment, lysis, binding, wash steps, and elution and storage. And after that, PCR were performed using the phosphor antibacterial resistance screening kit with the QuantiStudio real-time PCR system. And the panel targeted major resistance genes like BLA-NDM, OXA48, BLA-KPC, BLA-IMP, BLA-VIM for carbapenem resistance, BLA-CTXM for beta-lactamase, extended spectrum beta-lactamase, MCR1 for colistin resistance, 1A and 1B for vancomycin resistance, and MEC-A for methicillin resistance. And after all laboratory procedures were collected, data were entered and analyzed using SPSS version 30. A descriptive statistics were applied to identify the prevalence, bacterial distribution, and resistance profile, while association between patient demographic, clinical characteristics, and molecular epidemiology were identified using bivariate analysis with chi-square and multivariable analysis to identify the predictors independently. And the statistical significance was set at p-value less than 0.05. So now let's move on our results. Really, we have a lot of results, but to respect our time, I will present the most important results and sometimes briefly. Uh, um, so let's start with the prevalence of surgical site infection. During the study period between January 2024 and February 2025, 7,433 patients underwent the surgical procedure in 7 hospitals across Lebanon. Among them, hundreds of patients developed surgical site infection with an overall prevalence of 1.35%. Now, concerning the bacterial isolates, we showed that the majority of isolates belonged to gram-negative bacteria, which accounted 75%, compared to gram-positive bacteria, which accounted 25% only. And among them, Escherichia coli were the most frequently isolates, which accounted 26%, followed by Pseudomonas aeruginosa 18%, Klebsiella pneumonia 14%, and Staph aureus 12%. And this distribution suggests that the hospital-acquired pathogens contribute significantly to surgical site infection occurrence. Now, let's look on the antibiotic resistance of our bacterial isolates. Among gram-negative bacteria, we showed a high resistance to second and third generation of cephalosporin, penicillin, sulfonamide, and tetracycline, moderate resistance to fluoroquinolone and aminoglucoside, fluoroquinolone and monobactam, and low resistance to carbapenem and aminoglucoside. For gram-positive bacteria, we showed a high resistance to fosfomycin, penicillin, cephalosporin, fluoroquinolone, and macrolide, moderate resistance to aminoglucoside and sulfonamide, and low resistance to linezolid and tigecycline, and no resistance that reported to vancomycin, teicoplanin, and rifampin. And that indicated that this antibiotics remain the most effective treatment in our setting. Now, isolates were categorized as a multidrug-resistant organism, and we showed a high proportion of MDR, both in gram-positive and gram-negative bacteria, respectively 72% and 62%, and confirming the serious challenge of antibiotic resistance in surgical site infection. Now, let's look on the distribution of specific resistance strains. We showed a high proportion of extended spectrum beta-lactamase, which accounted 60%, and a high proportion of MRSA, 75%, while CRE accounted only 18.8%, where Acinetobacter reported the high level of carbapenem resistance. And now, to confirm our phenotypic finding, we analyzed the genetic basis of the multidrug resistance organism, and the molecular analysis showed the presence of several key resistance genes, like MEC-A in Staph aureus, in all Staph aureus and almost coagulase negative Staphylococcus, BLAST-TXM in Escherichia coli, Klebsiella pneumonia, Pseudomonas aeruginosa, Proteus mirabilis, and Enterobacter, Black EPC in Klebsiella pneumonia, and the Black NDM in Escherichia coli, Klebsiella pneumonia, Acinetobacter, and Enterobacter clausi, and another genes were not detected. So, and this finding confirmed that the beta-lactamase and carbapenemase genes are the main molecular mechanism driving antimicrobial resistance in surgical site infection. Now, let's look on the characteristics of infection in surgical site infection positive patient. We observed that the majority of infection were classified as superficial, 62%. And in terms of the time of surgical site infection, honest, we showed that the majority of infection appeared between 5 to 10 days to 20 days after surgery. And in terms of the location of appearance of infection, we showed that the majority after of surgical site infection, 87.7%, were identified after discharge, and this data highlights the needs for improving surveillance system that often miss in these cases. Now, let's look on the clinical characteristics and risk factors associated with surgical site infection. So, due to the time constraints, and I will present it quickly, concerning the sociodemographic characteristics, we showed that only the age distribution were a significant association with surgical site infection occurrence with a p-value less than 0.05. And about in terms of case type, we showed that emergency surgery showed a higher rate of surgical site infection with a significant association, 54.1%. And similarly, ICU admission showed a higher rate of surgical site infection, or 64.1% with a significant association. And regarding the surgical department, we showed that the orthopedic surgery showed the highest surgical site infection rate, followed by general surgery and the obstetric gynecologic with a significant association. And wound classification showed that contaminated and clean contaminated wound showed or reported a rate of surgical site infection ranking between or above 80% with a significant association, and with a significant association, yes. So now about the distribution of surgical site infection according to the duration of surgery, we showed that the procedure lasting 3 hours, ranking rate of surgical site infection between 50 and 100% with a significant association. And about the hospital stay duration, we showed that patients were hospitalized more than 10 days, showed a higher rate of surgical site infection, especially those admitted between 10 to 15 days with a significant association. And about concerning the antibiotic prophylaxis timing, we showed that the patients who did not receive antibiotic prophylaxis or received it later at the beginning of surgery reported a higher rate of surgical site infection with a significant association. And regarding the association between patient medical history and the risk factors of surgical site infections and risk of surgical site infections, so several comorbidities were identified with a variety of frequency and association, and we showed that the diabetes and heart disease, obesity, cancer, and the chronic renal failure and allergy reported a higher rate of surgical site infection with a significant association where p-value was less than 0.05. And now I want to skip this slide. To identify the predictors of surgical site infection independently, we applied the multivariable binary logistic regression. In this model, we showed that the surgical department, wound classification, and antibiotic prophylaxis and medical history remain a significant association with the surgical site infection occurrence. Now, I want to talk about the strengths and limitation of our study. This is one of the few Lebanese studies integrating clinical, microbiological, and molecular data on surgical site infection. And sometimes some limitation. Some hospitals declined to participate in our study, and sometimes sometimes we have a missing in some data in the record patient, and the distance between hospitals made data collection time consuming. So now, as conclusion, we conclude that in Lebanon, surgical site infection rate is within acceptable international range. Gram-negative bacteria were the predominant isolates. Pathogen prevalence and distribution varied across hospitals, with multi-drug resistance was commonly observed and the presence of specific resistance genes associated with this antimicrobial resistance. And many factors were associated with a surgical site infection occurrence, like emergency surgery, prolonged hospital stays, inappropriate antibiotic prophylaxis, and the lack of infection control structures in some hospitals. So, based on our finding, some recommendation on the practical and future research. For the clinical practice, to strengthen infection control programs in all hospitals, to ensure timely antibiotic prophylaxis and adherence to surgical guidelines, to maintain molecular surveillance, and to reinforce antimicrobial stewardship. For future research, to conduct multicenteral studies and to implement longitudinal surveillance, and to evaluate targeted intervention by rapid diagnostics or tailored prophylaxis and infection prevention bundles, and to expand molecular epidemiology studies like whole genomic sequences to understand the clonal dissemination and genetic determinant of resistance. And finally, thank you for your audience, for your time, and thank you very much.